Welcome, everybody, to Advancements and Breakthroughs in Andrology Conference. It is my distinct pleasure to introduce our speaker for today, who is Dr. Jake Fantus, who will be speaking on picking a penile prosthetic. Dr. Fantus specializes in men's health, focusing on the treatment of conditions such as infertility, erectile dysfunction, benign prostatic hyperplasia, BPH, testosterone deficiency, and Peyronie's disease. His clinical approach emphasizes holistic care, working closely with primary care colleagues to develop a personalized treatment plan that incorporates lifestyle modifications alongside medical and surgical therapies. Dr. Fantus has a particular interest in vasectomies, vasectomy reversals, inflatable penile prosthetic implantation surgery, and minimally invasive sexual function preserving BPH procedures. Dr. Fantus has authored more than 50 peer-reviewed articles and several book chapters in urology. He serves as a peer reviewer for prominent journals, including the Journal of Urology, the Journal of Sexual Medicine, Fertility and Sterility, and Urology. Recently, he was appointed as a committee member for the Sexual Medicine Society of North America. A Chicagoland native, Dr. Fantus completed his undergraduate studies at Washington University in St. Louis and earned his medical degree at Baylor College of Medicine. He returned to Chicago to complete his urology residency at the University of Chicago and pursued a fellowship in andrology, infertility, and sexual medicine at Northwestern University here with us. It is my pleasure to turn the stage over to you, Dr. Fantus. Thanks for being here.
Thank you so much for that introduction. I should have sent you an abbreviated thing, just that obviously my biggest disclosure is that a lot of the mentors at Northwestern are people that are near and dear to my heart and helped train me. And with that, the presentation is a little lengthy, so I'll try to stay on time. Great. So as Evan said, I'll be talking about picking the right penile prosthetic for the patient. This is a talk that I put together because there's a lot of stuff taught in medical school, residency, and things you learn clinically. As we know, there are two companies that provide different pieces of equipment for you to use, but I don't feel like there are many formal lectures that decide to tell you kind of the nuances between the devices and when there may be mechanical advantages. I have no disclosure. I do not work for either of the companies I'll be talking about. There's a brief outline. We'll go over some objectives, background of all the devices, as well as the devices themselves. We're going to play a game. I like to call this or that, which is just going to be a bunch of clinical scenarios and picking out which device may be best for different scenarios. And then I'll leave you with some take-home points. I think these were emailed out with the talk, but the end game of this talk is to understand the anatomy of the different penile prosthetics that are currently on the market, recognize when one implant may have some kind of an advantage, especially in different patient populations compared to the other implants, and then when there is no difference, that what becomes your go-to implant. I need to update this. This prevalence is actually old already. It's from the last guidelines, but realistically, there's almost 45 to 50 million men in the United States that struggle with erectile dysfunction. And what we're seeing is that the incidence is increasing with age at a similar trajectory to things like BPH. It said that about 40% of men by the age of 40 have experienced at least one episode of erectile dysfunction. And as we all know, the treatments consist of lifestyle modifications, phosphodiesterase inhibitors, pumps, injections, urethral suppositories, and ultimately penile prosthetics. A little bit of background about prosthetics. This is not a new concept. I know it seems somewhat new to market, but there have been attempts, as early as the 1930s using things like rib cartilage, acrylic splints, silicone implants, some bolstered other tissues, some that were readily migrated. But as you can tell, and we'll go through this a little bit, the history of the modern day implant, there were problems with flexibility, the actual material being reabsorbed, rigid materials eroding through the penis, lack of flexibility, again, migration due to lack of anchoring. Interestingly enough, in 1966, a plastic surgeon, Dr. Berry, described an infrapubic approach with paired cylinders, again, not inflatable cylinders, but paired cylinders that actually somewhat mimics the approach that some of us currently use today for implantation of inflatable devices. This is a nice manuscript by Passage that basically highlights the different timelines of the two FDA-approved inflatable penile prosthetics, the two companies, Mentor, which became Coloplast, and AMS, which became Boston Scientific, was purchased by Boston Scientific. You can see that the first prototypes were invented in the early 70s, with the more modern day ones materializing around the 90s. The Ultrex is the equivalent of the LGX. I have that circled. So the first, iteration of that device came out early in the 1990s, and then the Titan was introduced in the early 2000s. You can see towards the other end of this graph is when really the most novel innovations have come to our prosthetics in 2011, 2010, and 2012. And that really just goes to show you that the current on the market implant, with the exception of the new pump that Boston Scientific just released in 2024, have really stood for the last decade. So when you talk about failure rates, etc., we're talking about an implant that has stayed stable for about a decade. So let's talk about these devices. Again, the vast majority of what I'm going to talk about is regarding inflatables. I do bring up malleables because these are always an option, and it's important to know some of the nuances with these devices. There are actually 3 companies that produce FDA-approved malleables: Coloplast and Boston Scientific, which are the same companies that produce FDA-approved inflatables. But the Rigicon Rigil 10 is another FDA-approved device. They all have some form of a more bendable polymer with a core that's actually more rigid to allow this device to bend up and bend down to have an erection. Things that are important to know about these is they all vary in different diameters. The Coloplast and Boston products have 3 different sizes: small, medium, large, which are around 9.5, 11, and 13 millimeters in diameter. And that will be important when you actually tell patients that the size is fixed. It's also important when you're implanting these to make sure you don't implant a cylinder that's too large and barely fits, because it'll leave it at higher risk for erosion. The Rigicon, one of the major benefits is the device actually comes in 9, 10, 11, 12, 13, and even 14 millimeter cylinders. So it has a little bit more variety. You don't go directly from 11 to 13. So you may be able to get a slightly girthier implant in if you use that device. So why would you use a malleable? Well, they're way cheaper than the inflatables, threefold or even more so depending on the contract negotiation with companies. Again, a lot of these are used outside of the United States or in health and places where insurance is not readily available. They're easier to perform. There are fewer working parts. They require fewer incisions. There are fewer contraindications. There's less concern for device injury or hemostasis. What I mean by that is when you're implanting an inflatable, if you need to put another stitch in to close the corpora because you're worried there's going to be blood leaking out, or there's going to be a mandatory hole where the exit tubing comes out, with a malleable, you don't have that. So you can create a watertight closure, and although not ideal, could perform this on somebody who may not be able to fully come off of anticoagulation. There are few mechanical complications. Again, there are way less moving parts with these devices. There should be an asterisk here. These still can break, so don't tell people these are indestructible. I've definitely seen some of these break or parts of them migrate. And they don't require as much manual dexterity to use. That's a big one, especially in different patient populations, people that may have hemiplegia or something because of a stroke and lost the use of their dominant hand. Why shouldn't we use these universally? Well, again, patient preference. They're always rigid, which makes them less concealable. Somebody's going to be wearing, a Speedo or a bathing suit. It's very likely that you'll notice the imprint of one of these. It's less natural, again, because it doesn't have a rigid or flaccid phase, and it's always the same size. It's got a fixed girth, and then it has a higher erosion rate, which you may, surmise because of it's always rigid and putting gentle pressure on the tip of the penis. I would take this data with a grain of salt. A lot of this data comes from selection bias, right? The people who are putting this in often have sensory issues. People, again, with hemi or plegia, or people that have lost the use or sensation with spinal cord injuries. So while the data says it's true, I would take that with a small grain of salt. The majority of the talk will be on the 3-piece prosthetics. There are 3 pieces to these devices: the cylinder, which take up the place in the penis; the pump, which is in the scrotum, which is the on and off switch; and the reservoir, which is the area that holds the fluid. I put an asterisk here. There used to be a 2-piece. I originally had in this talk, but as some of you may know, Boston Scientific has removed that ambicor, that 2-piece prosthetic, from the market. So you may encounter it for an explant. It is unlikely you'll be able to use that when the last one expires. There will be no more of those devices in circulation. The satisfaction rate of these procedures is remarkably high. Depending on which device company, they quote between 96 and 98%. Well, that's great for them. I have this as more of a testament to us as practicing urologists and implanting physicians, that we do an excellent job of counseling patients and making sure they know what they're getting themselves into. This I like to call the 4th part of the 3-piece prosthetic, and this is the tubing. This was another reason I made this talk, is that I had a resident ask me, why did you decide to add rear tips? Why did you want an 18 plus 2 instead of a straight 20 in a particular patient? And a lot of this has to do with tubing. These are both companies' tubing sizes. And first, I'll turn your attention to the right side, which is the Boston Scientific's algorithm. And what you can see is in the middle column, they have legacy tubing. Now, these are for all their peniscrotal devices, regardless of length. All of their tubing is the same size, which you can imagine could create some problems, because as the fixed distance from where the tubing comes out gets deeper and deeper, if somebody's very large proximally, there's less and less tubing to pull out of the scrotum and have the pump set in a dependent portion of the scrotum. Therefore, they came up with this optimized tubing length several years ago to allow for larger cylinders to have longer tubing. Coloplast has done that again for their peniscrotal devices for years. As you can see in the left graph in the middle column, there are these graduated numbers of centimeters of tubing as the device gets longer, and then with the really large cylinders, the actual tubing is cut custom. The infrapubic length, which is true for both companies, is the same, and that's because it's a lot easier to hide this tubing. But it could become important to know that you have 16 centimeters of tubing to make sure that you have enough to get into the scrotum, again, depending on how proximal somebody is. Let's put this in an example. So the left is a peniscrotal device. The right is a peniscrotal device that I turned upside down to mimic an infrapubic device. For the sake of argument, the vast majority of tubing problems do happen in peniscrotal implants. So the question remains, I have a patient who's measured at 20 centimeters. For simplicity, X and Y are your proximal distal distances. They're both 10 centimeters. So we have the actual tubing length, which we get from our other table, which let's say we're doing a 18 centimeter or a 20 centimeter Coloplast, which is a 10.5 centimeters worth of tubing. We know that the tubing takeoff, and this is the vital thing to understand, the tubing takeoff is 3.5 to 5.5 centimeters, depending on the device, from the back of the implant. So when we seat the implant in, we have the starting length, which is 10.5 centimeters, minus the proximal length, which is measured at 10 centimeters. So we have about 0 to half a centimeter worth of tubing, plus the amount of length between the back of the implant and where the tubing comes off. And in this particular implant, it's 3.5. So now we have between 3.5 plus or minus about a half a centimeter, 4 centimeters of tubing. What that means is you look at your corporotomy and you say, you can take a ruler if you need to, you measure and go, is the pump going to go all the way down on the scrotum? And if you say, no, I need a little bit more length, that's when you add the rear tips. So by adding rear tips, let's say 2 centimeters and you're using an 18, you've all of a sudden given yourself that extra 2 centimeters of tubing. So again, it seems like some nuance that may be lost in some cases where you're looking and somebody goes, oh yeah, give me an 18 plus 2. But that's one of the reasons we choose to use different measurements. A lot of it has to do with how much tubing is going to be there. And likewise, you can use too much tubing. Too much tubing will leave redundant tubing in the scrotum, and obviously patients will not be happy about that. Let's talk about some of the different models on the market. Again, Coloplast makes the Titan and the Titan narrow base. The Boston Scientific AMS 700, that product line has the CX, CXR, and the LGX, which used to be the Ultrex. There are 2 other device companies, Rigicon, which currently has an inflatable device that is in clinical trials in the United States and is slated for FDA approval in the next several years. And Zephyr, which makes a great implant for transgender patients, is currently not FDA approved, so they're going to be beyond the scope of the talk today. Starting first with the Coloplast device, they have a BioFlex, which is a fancy name for one of their biopolymers that's compatible with human tissue. It doesn't cause reactions. A lot of this data comes from ex vivo studies. They've run tons and tons of different simulations and show that they can have greater than 6.5 million penetration tests without failure. Clinically, we know this number is way less than this, but this is, again, ex vivo studies. It could withstand up to 7,500 PSI. Later, I'm going to be talking about how much pressure we fill the devices with. A fully filled device is about 20 PSI. This tensile strength is important because while the device may have 20 PSI inside of it, as soon as you apply a pressure to it, say something like penetration, that pressure is going to go way higher than what you've pumped into it. and it has an FDA approval with modeling to help treat Peyronie's disease. The diameter is also important. We'll talk about those differences. The actual main Titan implant is 13 millimeters minimally across. Important to know to actually insert it into patients. And then it gets up to 21 plus or minus 2 millimeters circumferentially when it's fully expanded. The narrow base I would look at, it's 9 millimeters minimally. So the footprint is significantly smaller. But I want you to look at the fully expanded, which is again 17 plus or minus 2 millimeters as we compare it across companies. The other thing that is important is if I go back several slides, you can tell the difference in sizes of the implants. Coloplast has between 14 and 22 that are pre-made, and where it says cylinders only, tubing cut to length, those are custom cylinders. We have to attach them independently, but they have cylinders that go all the way up to 28. Some pros of the device itself: it has a hydrophilic coating, which makes it easily to slide into the actual corpora. It also absorbs different antibiotics, which allows you to customize which antibiotics that you want to use on it. The first circle I have on the top left is the 0 degrees exit tubing, which allows it to be more narrow at the widest point, allowing you to use smaller corporotomies. You can imagine bending over the device. The widest point folded in half is going to be right where that tubing comes out. And instead of coming off at an angle, coming off at a 0 degree angle, gives it the smallest profile. The cloverleaf reservoir, which is the part on the right, has two different sizes, 75 and 125 millimeters. It's approved to use both in traditional and ectopic placement, and it's designed to leave a minimal footprint. There is a lockout valve, which is the rightmost circle. The lockout valve on this device is on the reservoir. Important to know because you're actually able to test the lockout valve when you place it, especially in potentially high pressure situations like ectopic placement. You can gently press on the abdomen with the syringe still in place and see how much back pressure it will take to overcome that lockout mechanism. The last circle I have in here is the pump itself. This is actually one of the newer pumps, the Titan Touch, where you can press the button and the device will deflate itself without having to hold it. The more traditional model, you have to hold onto the actual deflation mechanism. However, some implanters prefer that because the profile of the pump is the smallest on the market. You may have guessed that every different implant has a different amount of fluid that is requisite to inflate it fully, and that's true and depends on the actual size of the cylinders. This is, again, their cloverleaf reservoir. Some implanters will prepare the same reservoir for efficiency's sake and always use 125, which is the larger of the two, and then underfill it. As you can see, until you get to 22 centimeters, you don't need anything larger. You could get away with the 75. But there is something important. If you're going to use the 125 reservoir and underfill it, you need to make sure you fill it enough. What I have demonstrated here with this really poorly designed animation is that the Pac-Man effect, as it's so called. It's when the device is filled so little that the actual fluid ends up in the head of this Pac-Man and the neck is folded over because it's underfilled. And when you go to exchange of fluid, there's no way to create that vacuum effect and pull that fluid in, rendering the device malfunction and potentially needing revision. I want you to remember that number, 80 milliliters, because it's going to come up again. So do not fill this less than 80. So what are some of the big negatives of using a Coloplast device? The first, and the one that their competitor is going to point out, is the dog ear. The dog ear happens when the device is not completely full and the patient has a flaccid penis. This implant only expands in girth, so with a fixed length and no intrinsic support to this BioFlex material, this depiction of the dog ear is just what happens. The penis kind of folds over on itself. You may actually see the corner or the crinkle in the actual device itself. And again, important to talk to people. If the flaccid penile appearance is important, this is not a good implant. It expands in girth only, as I mentioned. There's an asterisk here. We'll go over some data that shows some minimal length expansion, but suffice it to say, it's probably not a perceivable difference. This is both a plus and a minus. So you need to actually have some thought process to the antibiotics. We have the best antibiotics for skin organisms already impregnated. You need to manually figure out which antibiotics you want to use. And then there's a recent paper in JSM talking about when you impregnate antibiotics under the surface, it's possible that different irrigants could potentially wash off those antibiotics. Clinical data has not yet corroborated this. Again, this is ex vivo studies of putting small amounts of antibiotics on their surface, cutting off that part of the device, putting it in a petri dish with bacteria, and irrigating versus not irrigating, and showing that irrigated devices may lose some of their antibacterial coating. Boston, as I mentioned, has 3 products on the market. They have the CX, which would be considered their standard implants. They have the CXR, which is their narrow implant, which is similar to the tight narrow base. And then they have the LGX implant, which expands in length up to 25%, which is their most marketed implant. And for that reason, again, you're going to see a lot of studies comparing that LGX to the Titan. Their standard implant, however, is the CX, and you'll understand why at the end of the lecture that's the case. You can see the different minimum and maximum sizes. The minimums are the same between the CX and the LGX, and the maximum is several millimeters smaller. The smallest inflatable on the market is the CXR, which may seem like a downside, but there are definitely some situations where this may be a benefit. In terms of sizes of the actual devices, they're different. The CX goes up from 12 to 24 with no customizability beyond that. The LGX goes from 12 to 21, and the CXR stops at 18 centimeters. Now, those cylinders are very different than the Coloplast ones. They're multi-layered. They have 2 silicone layers with this Dacron fabric middle layer. And that Dacron is the magic of how you can actually create the LGX. The different way that material is woven allows for either girth-only expansion that we see with the CX and CXR, or it's fenestrated almost in a way that allows for length and girth expansion with the LGX. They've nicely coated the outer silicone layer with inhibizone, which is rifampin and minocycline, based on a lot of clinical data from the early 90s about which bacteria were most likely to cause penile implantation infections. And because of this Dacron sheath, as well as this inner cylinder, there's actually support of the penis, meaning when this is deflated, that the penis actually looks way more normal in a flaccid state because this is actually acting as support. Reservoirs, just like the Coloplast equivalent, there are several Boston reservoirs. There are 2 spherical reservoirs, the 65 and the 100 milliliter one. And then there also is the AMS Conceal, which is a flatter reservoir that works really well for ectopic placements. Now, this is a study from Dr. Clavel looking at failure rates of over 500 AMS devices, and they found a disproportionate number of failure rates in the reservoir in concealed reservoirs that were filled to less than 80 milliliters. What you can see in figure A is almost a dimpling effect when they pulled this reservoir out of the patient because it was completely empty. And what they noticed when they filled the reservoir is this pinhole defect at the top. And the hypothesis was that if the reservoir isn't filled to at least 80, when it deflates, it can cause the actual balloon to stick together right at the top. And after some use, that will eventually tear a small hole, which leads to complete device failure. So I said to remember the number 80 from the Coloplast devices. If you're using a concealed reservoir, I would still argue you should fill it to at least 80 milliliters based on this data. So I just told you it offers great support. It's got 3 different models. It can be used in all kinds of different settings. It can expand in length. What are some of the downsides? Well, again, as I said, the flagship model that they market is the LGX, and the LGX has been shown to be less rigid at all different fill pressures. The girth is smaller. I jokingly have this arrow pointing to what are these? These are the Gore-Tex sleeves that cover the tubing. These are put on because of manufacturing issues with the actual device. If that tubing is put in continuity with the actual cylinder for long periods of time, depending on temperature changes, it can actually cause it to bind to and then tear off the cylinder and ruin that outer silicone layer. So these are there to protect the implant and can be removed during surgery. The other thing you'll notice with the circle is that that is not a 0-degree takeoff. And for that reason, despite the minimal or a similar footprint in terms of minimum girth, it does require a slightly larger corporotomy to accommodate. But again, no major differences between the 2 different companies. So let's talk about situations where we may pick one device over the other. The first is the big penis. Is a 56-year-old man who previously had poorly controlled diabetes, and he completely turned his life around. His A1C has been 6.5 for the better part of a year. He's failed everything, orals, injections, VED, and he's come to you to discuss penile prosthetic. No hernias, plaques, testicles, scrotum's all fine, but you do a stretch penile length and it's 18 centimeters. So doing some quick math in your head, you start thinking, well, what would he be approximately? If he's 4, maybe it's not a problem, but if he's greater than 8 centimeters or 10 centimeters and has a penis greater than 25 centimeters, what implants are going to fit him without significant rear tip extenders? And again, we had talked about this. The Coloplast has slightly larger cylinders that can accommodate this. The CX model of the Coloplast goes up to 24. So again, that may not have many rear tips, but if this thing is going to get closer to 28 or 30, you would probably have significant rear tips if you didn't choose larger cylinders. And then also talking about rigidity of the implants. I had alluded to this earlier, but there are plenty of good studies looking at the rigidity of these implants. This was actually a study done by a medical school classmate of mine, Dr. Scoville, and it looked at both direct and horizontal loads onto different prosthetics. I had mentioned that they always compare the LGX to the Titan, and we'll talk about this a little bit later. But you can see the 18 and 21 centimeter LGX compared to the 18 and 22 centimeter Titan. There is not a 21 centimeter Titan, so these are 22 for comparison. The red line that I have superimposed on this top right graph is what is thought to be necessary for penovaginal intercourse. And what you can see is that the 18 and 21 and all the fill pressures had some buckling prior to being able to achieve necessary penetration force. And that the shorter Titan had no problems, and the larger Titan at full pressure seemed to have satisfactory rigidity to exceed this force without any kind of buckling. The bottom graphic is showing with the buckling how much deviation or displacement there is, and you can see the LGX 18 and 21 had significantly more deviation, some of which is greater than 2 centimeters, which you can see on figure B on the left with massive deviation, which can obviously cause problems when attempting intercourse. Horizontal rigidity didn't seem to be as different as that axial rigidity, and a lot of this has to do with how big the implant was and how inflated it is. Interestingly, the Boston implants, the more inflated they were, the more rigid they were horizontally when they are deflected with a weight. Whereas the Coloplast ones, because they filled with more fluid, ended up actually having more deflection when the weight is placed on them, which you can see in the right-hand column of the two pictures. Now, let's talk about the data being used for rigidity that's marketed to consumers and likewise to all of you. This data, then again, I have part of this, the bottom part is pulled from one of the Coloplast brochures, talks about the percentage of maximum rigidity with how full the devices are. 10 psi is half full, 20 psi is completely full. What you can see is when the devices are completely full, they achieve, the 100% of their rigidity. Looking at the curves above, you can see that the Coloplast on the left and the Ultrex on the right requiring is more of a flat line, requiring a lot more to be pumped in to get to that rigidity. The question you may be asking is how many people don't pump it all the way up? And we recognize that a significant amount of people aren't able to get the device 100% inflated. So this can come into play when people can only get it to about 15 psi. Interesting, what's not shown in this graph down here is the other components of the AMS 700 CX/AMS Ultrex graph, which is that top curve. The top curve is the CX implant and looks strangely similar to the Coloplast Titan implant. So if there was a third column on this table right here that said CX 18 centimeter, I presume it would be as good, if not potentially slightly better than the Titan. So again, this is comparing apples to oranges. Now, everything I just told you is ex vivo data, right? These are people taking the device and putting it on a vise or a manometer and testing these shear forces. This is an interesting study that Hackey and Perito performed where they actually placed the device into the corpora of cadavers and tried to see how much pressure they could apply in vivo or in a cadaver. And what we found here, if we go all the way to the left of my first box, and again, about 1 kilogram worth of pressure is necessary for intercourse, is that at an 18 plus 1 centimeter rear tip, the LGX and the Titan are inadequate. Just for reference, at 517 milligrams of mercury on the top is equivalent to about 10 psi. So at 50% fill, both the LGX and Titan with a single centimeter on them were inadequate for penetration based on the amount of force generated. However, when the 1.5 centimeters of rear tip was added, the CX, the LGX, and the Titan improved, with only the LGX still having difficulty achieving that 1 kilogram load. With the addition of a second centimeter of rear tip, so 2 centimeters total of rear tip, all three of the devices were able to achieve that, which we could talk about the merit of rear tip versus not, but it does seem in a cadaveric study that some rear tip can actually improve device rigidity. The second kink just represents the fact that the device is not only bent once but twice, and it could significantly limit the usability in a sexual situation. And then if we look at full filling pressures, regardless of the actual device or how much rear tip, we see again at the full 20 psi, most devices have adequate penetration power. What about the girths achieved? So the same study looked at the, this is actually the original Scoville study, looked at the girths achieved ex vivo, and they found very much what we said, that the devices do expand again to that 17 to 18 millimeters, or about 18 to 22 millimeters for the Coloplast device. If you look slightly above, you can see that all of the Coloplast devices did expand between 18 and 18.4, or 22 to 22.8 in length. But again, that sub-centimeter difference is not necessarily perceivable, and this is ex vivo. I've not seen a study that tried to replicate this in patients. So what are the big takeaways here? For this patient, I think it's important to ask him how important his flaccid penis is. If it's a non-starter, that his flaccid penis needs to be normal, then I would not pursue a Titan implant with him. If that's important, the CX would be a good option. If rigidity is important, well, I just showed you all the graphs. I think a CX or a Titan would be a reasonable solution. If maximum girth is important, the data would suggest the Titan is a slightly girthier implant. And then what shouldn't you do here? Well, any narrow base, unless for some reason you got in there and the guy had terrible Peyronie's or something that was undiagnosed, really would stray away from an LGX in this situation where the person had a really large penis, again, due to those rigidity issues. The other thing is, as they said, the LGX maximum size is 21. If this person really is, 28, you're going to have 7 centimeters of rear tip, which is going to displace that tubing and can cause a whole host of other issues. I did discuss some rear tips up to 2 centimeters, increasing rigidity, but there aren't good studies showing if you have too much of a good thing, could potentially be a bad thing. And the last thing, unless the person wants a malleable, shouldn't do that unless that's their preference. Next case, we got a 62-year-old man who is watching football. He watched a Bears-Packers game and got depressed, and then saw this commercial and got even more depressed, realized he had a bent carrot. He has been on ICI for a number of years, but he's just fed up with it and wants to make a change. His exam doesn't have any hernias, doesn't have any problems with the scrotum. He's got adequate stretch length, but he's got about a 2 by 1 centimeter mid-shaft plaque and an erect exam with a 45-degree dorsal curvature. So I'd mentioned earlier that Coloplast had attained a FDA approval or indication for use with modeling to help with Peyronie's disease. But Dr. Chung did a very nice study, and Dr. Brock actually looking at other devices to see if they're equivalent. And what they found is that the AMS 700 CX device, again, very important, CX device, was equivalent in modeling. This Kaplan-Meier curve is actually device survival, looking for explant for any reason, failure, infection, or otherwise. And they found no significant difference at 5 years between men that were implanted and modeled with a CX versus a Coloplast Titan, which is incredibly reassuring that both of these devices seem to be fine. For this case specifically, beyond the scope of this talk, we definitely need to manage his expectations. Does he need a plication? Does he need a scratch or some other kind of incision or excision or grafting along with the device? How big of a defect would you leave him with? Ideally, not bigger than 1.5 centimeters, or you would patch that with something. And then make sure the patient understands the changes in his penile morphology after getting an implant, specifically length and possibly girth issues at different places on his penis. What shouldn't you do? Probably wouldn't use an LGX for the same situation as before regarding rigidity, and because it hasn't been rigorously tested in the setting. And then please do not use an inappropriately sized implant. Ideally, we would make everybody slightly bigger than they are, but I think one of the biggest things we can do is harm by oversizing a person to a point where the device causes buckling and chronic discomfort. Nobody wants to be 0.5 centimeter bigger if they have pain every time they inflate their device and no longer want to have sex. Moving on, let's talk about the brittle diabetic. Admittedly, I didn't know what a brittle diabetic was until I was a PGY 5. I thought a brittle diabetic is somebody who is frail and a diabetic, but for those who don't know, it obviously means that they have very labile blood sugars, even when they do a good job of trying to keep it under control, that they respond very sensitively to perturbations in their blood sugar. So this is a 45-year-old male. He's got type 1 diabetes. His A1C is ranged all over the place. It's currently 7.2, but it's been anywhere from 6.9 to 7.8. He's been managed with an insulin pump for years, and he's failed all other forms of erectile function treatments. His exam is completely normal. So some device concerns are, do you have an A1C threshold for any device, for a specific device, for a specific type of implant? And then what are you considering your antibiotics? So some devices have them impregnated. Are you changing what your intravenous antibiotics are going to be based on what you've impregnated? You also have the choice of using antibiotic irrigation. What type of irrigation are you going to pick based on the scenario? This paper gets quoted quite frequently. It's a BJOI multi-center study with the vast majority of the data coming from the Middle East, looking at device infection rates and A1C values. This beautiful ROC curve is going to tell you that 8.5 is the number that you want to remember as the number where there's an inflection point in terms of preventing infections. But if you look at the numbers that I've highlighted, this cohort has got 72% Genesis coloplast. That's the malleable. And 200 inflatables and very few Boston devices. So this data is really mostly applicable to coloplast malleable devices and may not necessarily be the most applicable to other devices using that as a threshold. So I would take this data with a grain of salt. This data, however, echoes this, and again, given its limitations, this is a retrospective claims database which has a very specific population. But what's interesting is they come up with a very similar threshold. On the left, we have hemoglobin A1C values, and we have revisions, and I've circled revisions with infection, and then they have different stratifications, less than 6 all the way through greater than 10. I would have loved to see 8 to 9 and 9 to 10 to break down that 8.5 threshold. My assumption, and I do not know the answer, is that these were put together due to small number sizes, which you're forbidden from using in these data sets. And what you can see is the odd ratio of IPP revision with infection on the right, and you go from 1.4 all the way to almost 5 greater than 10. At some point when you're getting close to that odds ratio of 2, you should really be thinking about potentially optimizing that before surgery if it's possible. I typically use somewhere between 8 and 8.5 extrapolated from this data, and I like to see that number coming down to make sure the person has good perioperative glucose control, meaning that somebody who is 7.5, 7.9, 8.2, well, they're not under 8.5, but they're going up, whereas somebody who's 10, 9, 8.2 is on the correct trajectory. I'd much rather implant the latter than the former. So which dip are you going to use? Fortunately, Boston already has something for you. They have that pre-made dip that has been shown to stop the vast majority of skin organisms. Coloplast, you're going to have to do some thinking. Do you want Vancomycin Gent, Rifampin Gent, Bactrim, any other combination of absorbable antibiotic you can think of? Do you want to add antifungal agents to the dip? And again, there's going to be more literature coming out with the combinations of these adsorbed antibiotics, plus or minus different irrigations, potentially affecting what remains on the implant itself. So the inhibisone data is very good. It is somewhat antiquated now, but if you look at the traditional data showing infection, these were designed to stop things like staph epidermidis and lutegenesis, which were the by far and large the most common causes of device infections, and they've virtually been eradicated by inhibisone for the Boston devices. The study in the bottom right is actually a study from Wilson in 2011 using the same combination of antibiotics on the Coloplast device showing similar efficacy. They showed a slightly statistical increased improvement in zone of inhibition control, meaning that it kills more bacteria, but this wasn't carried out over the course of a month. And again, I do struggle sometimes in being able to translate what's done in a petri dish to clinical scenarios. I've yet to see a study looking head-to-head comparing these two showing a clinical infection difference. The issue is these aren't the organisms we're seeing anymore, right? We've prevented those common organisms. So now we're seeing a lot of what would be considered more resistant bugs, Candida, MRSA, E. faecalis, Pseudomonas, Serratia, Klebsiella. A lot of these that have different resistance patterns and a resistance to those traditional antibiotics. This article by Dr. Gross, I know Dr. Wilson quotes this, and they talk about using Vanc, Zosyn, and fluconazole as IV antibiotics in absolutely everyone. But I think we can be smarter than that. I think what we really need to be doing for both the adsorbed antibiotics as well as the IV antibiotics is to consult your local antibiogram. What are people getting in their infection, and how can we be mindful to not overtreat and get any antimicrobial related complications from our patients? Obviously, things like C. diff and GI issues. So we have got great data that's preclinical. We don't have as good of clinical data. And again, I would caution you for those that read JSM and see these studies showing, oh, this zone of inhibition is larger in this device. At 30 days, it's larger in this device. Until we have robust clinical data showing a benefit one way or another, I would not make any of this practice chasing. So again, please do your best to use your antibiogram and choose the appropriate antibiotic combination at your hospital. So again, ensure good glucose control. Make sure you talk to the patient. I tell patients that they're at a higher risk, regardless of what device they choose in this circumstance. It's important to be very transparent with them. They are at higher risk. All data would suggest that diabetic men are at higher risk for infection. If you want to quote them a number based on the information I showed you, obviously you can. If you don't want to quote them a number, I would just tell them they're at higher risk. And then use a coded device and consult your antibiogram. What shouldn't you do? You shouldn't use a Titan with normal saline and no dip. I will make one shout out. Dr. Francois Ede has made his living doing this with a no touch technique, especially with patients with allergies and other issues where they can't have it. Unless you perfected this technique, I would not use a device that is not dipped in some antibiotic solution. What about the fibrotic phallus? 38-year-old. This is the guy with recurrent stuttering priapisms that's come in. He's been drained about 100 times. He just had a penoscrotal decompression. His exam's normal except for he's got terrible woody fibrosis of his penis and some healed scars from his different shunt procedures. Again, implant choice here is critical, but so is approach. As somebody who does 75% of my virgin cases, and for pubically, this would be something we should be thinking about going penoscrotally, especially if you think you're going to need to do some kind of corporal excavation or more advanced maneuver to really debride a lot of that dead necrotic fibrotic tissue. You need to be able to counsel patients on expectations for what the penis is going to be like afterwards. Sure, you're going to remove a lot of that fibrous tissue, but there may be more. There may be dark tissue that's hard. You may never restore them to what they had before they started having priapisms. And then what implants are you thinking about? Well, I think the ones that you are thinking about are ones that may be able to fit in a narrower space. People with terrible Peyronie's or people with terrible priapism disease can have very fibrous tissue that won't expand. You may not be able to get the normal devices in. So these would be things like the Titan Narrowbase and the AMS CXR. And again, if you're really reaching for the smallest one, you think you're going to struggle, that's where that CXR may have a benefit because it is the smallest footprint of any device on the market. Last but not least, the most challenging patient, the penocentric patient. These are often the most tough to deal with in clinic. There's a 51-year-old who had prostate cancer, had a prostatectomy several years ago. He's failed orals and refuses the notion of having to put something in his penis or use a vacuum. He says he's lost length. He used to be 12 inches and now he's only 3. He wants the biggest implant on the market, and he's also concerned that somebody's going to notice he's got an implant, so he wants it to look natural. He's got no hernias, no plaques. He's got fine exam otherwise, an adequate stretch penile length, which you mutter under your breath, there was no way that you were 12 inches. Definitely the most challenging patient. And this is true with all implantation surgery. It's always important to underpromise and overdeliver. You don't want to promise somebody something that you can't do or something that you might be able to get done, and because you don't want somebody leaving disappointed. It's important that patients understand this is a functional surgery. This is not a bigger, stronger, better surgery. It is, I'm going to take you from having no erections and give you erections that are meaningful that you can use with your partner. So this less of a what should you offer, more what shouldn't you offer. And that is really going to come down to what he wants. So again, does he care about his flaccid state? Does he care about how much girth he has? Going along with this, and this is something that you all are likely to encounter, is what if he asks for potential things to lengthen his penis. Fortunately, there's this was talked about at the last AUA, and it was recently published in the JSM. There are some guidelines, or rather a position statement, that offer guidance in this area. So there are several different procedures, and we're not going to talk about filler, etc. But suspensory ligament division, which could be a reasonable consideration if you know how to do this. The problem is, if you look at a lot of this data, this is not just suspensory ligament division given somebody a centimeter to centimeter and a half. It's typically coupled with somebody actually doing like a corporopexy, where they do a buried penis repair, or somebody does an escuticectomy or liposuction. So it's not usually suspensory ligament by itself that helps create this. And there are risks, right? All of a sudden, the erect penis is not holding itself up. When you pump the device up, it's now pointing to the floor, which is not natural. And I presume a patient like this would probably not like this. Graft and flap and sliding and slicing techniques, all of these need to be done in an IRB only, unless it's something like a buried penis repair, or a scrotoplasty that we know we have good data on. But any other adjunct maneuvers to increase penile length, especially removing parts or slicing into the corpora to extend it, have been associated with things like glands necrosis, penile loss, permanent penile numbness, and rates between 2 and 12%. Which, again, if I told the patient they had a 10% chance of losing the head of their penis, I think it's unlikely they would pursue this. And personally, I'm not comfortable offering that outside of the setting of an IRB. So when somebody comes in asking for these, we have a place to turn to kind of direct them. So counseling is key here. Again, you're managing what he wants. If he wants that natural erect, and non-erect state, the CX is probably best. If he needs to expand in length because that's what's important to him, you can tell him the differences in rigidity and size. If he needs a maximally girthy penis, you can tell him that. But again, if he wants to be normal, I really shy away from doing any of these adjunct procedures. So some take-home points. Most situations can be handled by either company's device, and soon potentially to be a third company on the market. Be very mindful of patient factors before picking the device. Make sure to manage expectations and don't offer what you can't deliver. Again, I don't sway a patient one way or another. I give them both implants. I tell them these are the highlights of both of these. If one of these things is important to you, then this would be an implant. If neither are important to you, well, then I get to pick. And how do you pick what your default is? I didn't talk about this at all. It's because I think that I left reps out of this conversation, and this is maybe the most important part of the entire talk, is to know the reps in the OR. Good reps are people that are going to be there present during the case, reminding you that you forgot to fill the reservoir, reminding you that you measured the side, you said you're going to measure it again, saying, hey, something doesn't look right. Maybe you want to test for a crossover. Maybe you want to do X. I don't care that anybody's second guessing me. At the end of the day, I want the right thing for the patient, and I appreciate that level of involvement by the reps. This is more than somebody taking you out to dinner. This is the person actually going, hey, why don't you come to a course somewhere? Let's go look how to do a new technique you don't know how to do. Let's go take you to somebody on a day they have a lot of complications, or people you want to do, people with a lot of corporal fibrosis. Will get you somewhere that has 2 or 3 of those so you can see the technique live and talk to the surgeon. And that, you're in a case and it's difficult, and they go, I know just who to call. We can call your mentor, or I have, Wilson or Perito or somebody else on the line that I can help you with. So get to know your reps. The ones that are helpful will probably be the ones that dictate what your default implant is, because you like working with them and they're able to get you out of sticky situations. And with that, I will take any questions.
Jake, that was a really great talk. I had one quick question. I think it was in one of the slides when you were mentioning possible issues with the dip for the Coloplast Titan with chlorhexidine and Uricept. Is that something that you worry about? Is that something? I mean, obviously there's not any literature on that. Do you do anything differently in those cases?
No, I mean, that manuscript was looking at Vancomycin dipped implants, and then using Vancomycin irrigation versus Uricept versus saline versus devices dipped in Uricept, and then looking to see how much of the antibiotic remained on the device when it was put in culture in a petri dish. A lot of the infections we're going to get are going to be inoculated at the time of surgery. If you look at explant data, we know that there is some bacterial count on all of these devices when you explant them, whether or not they have a clinical infection. The thought, again, with inhibizone is it lasts for days and weeks, and that washing off the antibacterial coating may allow these colonies to form. Again, I haven't seen this be well substantiated in any clinical data. I have not changed my practice. I still use Uricept irrigation. I have not yet transitioned to doing Uricept dip devices. Part of me just does feel more comfortable with antibiotics without a shred of evidence to support that. But yeah, I've changed all of the irrigations partially because of cost and the pharmacy, and I don't know where everyone else works, but the pharmacy, when you ask them to create a dip that's more concentrated and give the IV ones, it creates a whole host of confusion, especially at the hospitals, the VA.
And then one quick question just on logistics. Say do you tend to stack your implants in terms of company? If you're having, 5 Boston implants on your schedule, do them all in one day, or would you do Coloplast in Boston? Does that confuse your OR team or your reps at all?
That's a great question. I think at the main hospital, it does not matter at all. We have stuff on consignment, so it doesn't tend to be an issue even if somebody doesn't show up, whether or not it's either company. Sometimes I like talking to different people. Uh, but at the VA, I really do try to stack it because otherwise I'm going to get a dip for every implant if it's Coloplast or Boston. So again, I agree with you. It really depends on your staff, but I personally don't have a problem if the reps see each other. I mean, I'm doing what I think is right for the patient. I don't care who shows up to the OR as long as they're helpful.
And Dr. Fantus, thank you so much for taking the time and speaking with us. It was a really wonderful talk, and kind of the nitty gritty and some of the specifics on how you select devices really helpful for people of all levels. So, if anybody else has a question, I'll take a look through the chat as well.
Yeah, feel free to email me as well. I think I know a lot of people on here, and if I don't, I'm sure somebody can get you my email. Dr. Brannigan and Evan, thank you very much for inviting me. And please, if there are any questions afterwards, please let me know.
Thank you so much. Have a great night, everyone.